Good afternoon, everyone, and I want to welcome our participants. I see the numbers are going up, and we have a really interesting topic today, and it's great to have all of you on the call. So I'll just wait whilst people continue to join us. Many of you will know of the ESDR Kitchen now, something which we started a while ago to make sure we can connect and exchange ideas and topics. And there are 4 themes in our kitchen, as you will see: the recipe book, sweet and sour, freshly baked, and molecular cuisine, all of which give different offerings that we can take in these half-an-hour lunchtime breaks. And so today we have a sweet and sour ESDR Kitchen episode, which is kindly supported by an educational grant by UCB. And we have 2 excellent speakers, leaders in their field, to speak on 2 aspects of a topic that we thought would be really interesting to discuss. And the title of the topic is The Journey from PSO to PSA, Can We Prevent It? And I have the great privilege of introducing our first speaker. And this session will be started by Professor Thaçi speaking on the topic, and I'll invite Professor Thaçi to start sharing his slides in the background, if that's okay. And I will say a bit about Professor Thaçi. He has, one moment, let me just get the right screen up here. Yes, he graduated from the University of Frankfurt, and since then has been a leader in psoriasis research. He has been, since 2013, director and full professor at the University of Lübeck, and he's been involved in numerous investigator-driven trials, both nationally and internationally, on psoriasis. He's published in several high impact factor journals, including the New England Journal of Medicine and the Lancet, and he is a member or the steering committee of the Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, or GRAPPA. He's a member of the International Psoriasis Council and the IEC as well. There are many additional accolades, but I will stop there, if that's okay, Professor Thaçi, and invite you to open the discussion over the next 10 minutes on this really interesting topic. Please, the floor is yours.
Thank you very much, Niall. It's always a pleasure to be in the kitchen. And it's a different way of being in the kitchen, to be honest. And I asked my question, can we really prevent it? It's so easy. Nowadays, I don't know if you are aware, but this is a carnival time. In the carnival time, you go to the parade and you will find the answer. It's very clear. Yes, we can. Yes, we can in US, and yes, we can also in Europe too. These are my disclosure, which I will jump very fast, and I will come to that, what I think is very important to all of us. What is the journey from psoriatic arthritis? You know, this was my first patient, my first journey. And this is a journey from psoriatic arthritis to psoriasis. And it's the opposite. After 10 years, what happened? We're not able to stop the radiographic progression in this patient. So it means if you look at this journey from the mild psoriatic arthritis to the severe psoriatic arthritis, I think today we do not see hands like this. I think that today we can really prevent the hands like this. So it means the journey from a mild psoriatic arthritis to a severe modulating form of psoriatic arthritis, we can prevent it. So yes, we can do. But the question which usually comes is, what happens when the patient are having a psoriasis before they get a psoriatic arthritis? This goes usually in the phases. We have the preclinical psoriatic arthritis, where nobody believes that this patient might develop a psoriatic arthritis. Of course, it will be excellent if we are having a biomarker, any chance to look for this, to find out this patient might develop a psoriatic arthritis, but we don't have it. Suddenly, we are trying to find out in the next stage, in the subclinical form of psoriatic arthritis, where the patient are claiming about arthralgia. We cannot see this. And if you do, for example, an ultrasound, if you have a very experienced ultrasound specialist, he'll be able to say, look, I think this patient is having subclinical form of psoriatic arthritis, and you don't see any kind of the psoriatic arthritis, or furthermore, you don't have any symptom of psoriatic arthritis. And when we have this transition phase, where the patient having arthralgia, where they are having also the problems, the morning stiffness of the joints, we see this can be the first step toward the transition. And then we have a psoriatic arthritis. The first question that usually rheumatologists ask, they are predicting what will happen in 2050. You know that in Germany, we love to do this long-term prediction. And they have done different scenarios. This was published last year from our rheumatologist colleague. It was a national health insurance data from 65 million. So if you look at the different scenarios, whatever scenario you take, they thought, oh, in 2050, we'll have an increase of patients with psoriatic arthritis. And in only one scenario, it was predicted in the future, we'll probably have 30% less psoriatic arthritis. And this will happen at the age of the time point of 2040. Is this true or not? I will convince you that is not the case. If you look to the 24 years ago, we started to think about it. Can we really prevent psoriatic arthritis by adequate treatment of psoriasis, for example? Is this possible? And one of the papers was shown that if you treat with biologic and you compare to the patient who are treated, for example, with a phototherapy, and it is statistically significant difference, this tiny one, but it's still, after 4 or 5 years, is showing that the patient who are treated with biologics, they have less psoriatic arthritis. It means, according to this paper, that early therapeutic intervention may delay or at least reduce the risk for the development of psoriatic arthritis. You see that from the beginning, it was not very clear. Can we prevent or not? But it was like postponing, reducing the number of the patient with psoriatic arthritis. Furthermore, going to the more retrospective studies and looking to the larger group of the patients who have been treated, like this group in Argentina, they have analyzed patients who have been on topics, patients on conventional DMARDs, and patients who had a biologic DMARDs, and looked how many of the patients developed in a psoriatic arthritis. So it was for the first time in a larger group showing how important it is to look retrospectively who will develop psoriatic arthritis and are we able to postpone, to delay, or even prevent the occurrence of psoriatic arthritis. And indeed, what was shown that patients who are treated with a biologic DMARD, with biologic, they have a decrease of 80% of psoriatic arthritis, 80% decrease. Also, conventional DMARDs are not bad. If you look 50% decrease in the incidence of psoriatic arthritis, it's showing that an early and adequate treatment of other patient is very crucial, and that what is really a negative predictor is only topical treatment. Of course, if the patient have a predisposition like a nearly involvement, they have a highly significant risk. So it's showing it's not only the treatment, it's the combination, probably genetic predisposition, psoriasis, disease severity, and also treatment. And treatment is becoming very interesting the last 10 years. And especially, how can we explain this? You know, for rheumatologists, they always think, oh, it's something which is what is very difficult to explain. But today we think that it might be that circulating memory cutaneous lymphocyte antigen positive T cell, which are coming from the skin, from the psoriasis, they have been found to circulate, and the recirculation, they are landing also in the joints. Today, we know that the same cells might be in the skin and also in the joints, showing how important it is to treat the skin. For our rheumatologists, very crucial, but I think also for all of us, understanding importance of adequate treatment and probably also early treatment, because once we have an arthritis, it's very difficult to prevent. So we think it is possible. And the question is only the resident memory T cells, or probably it can be that it is also the regulatory T cells. And I think there are differences in regulatory T cells. We are learning that these regulatory T cells, the previous regulatory T cells in the joint, behave different. And there are Th17 cells which do produce IL-17. But also the milieu is very important. Where's the IL-23 and how this is influencing the prediction of response or not response. So finally, if you go in the literature, and I have done this for you, you will find differently. Some of the studies will say, if you treat early, you may decrease the risk of psoriatic arthritis. Some of them say, okay, this is the higher risk for psoriatic arthritis, beside the treatment with the biologic DMARD, but this is sour, I'm more for sweet. And then in some patients, we don't have an answer. So it means from the literature, we cannot say what is really that, can we prevent or not. But there was recently in a retrospective study, done in Trinetics, and a very huge study. And it was shown that if the patient were treated in different countries, in a different hospital, from the patient record, this is called Trinetics database, where it's a huge number of the patient. Finally, it was able to show that if the patient are treated, it depends which kind of treatment. For example, treatment with TNF cannot reduce same like IL-17 or 12 and 23. I don't know if it's a bias or not, but that what matters is also which patient we are looking for. If we are having patients who have only first biologic, very early treatment, then we can have some conclusion. But if you take the switchers, for example, after TNF, you switch to IL-12, 23, almost half of the patient will get psoriatic arthritis. So it means first treatment should be the best treatment. And I think this is a very crucial, very important in patients with psoriatic arthritis. If this is the case only with IL-23 or IL-17 are playing in a very important role, this is a matter of investigation in the next prospective trials. But even rheumatologists are looking at this differently. You know, rheumatologists never thought that we will work, that they will be retired earlier. For example, if you look to the patient profile A, if the patient have any pain and they have used a biologic and they have a nail, which are a predictor, means for the PASI is playing a very important role. Severe psoriasis is increasing risk for the development of psoriatic arthritis. So it's not only treatment, it means also the disease severity. As less the disease severity is, the probability is lower. And I think it's the same, even in a patient who have no treatment at all, no pain at all, no nail lesion. In this patient, if, for example, you have a PASI of 3, it is a 50% less risk for the development of psoriatic arthritis. So finally, coming to the end of my talk, what can we do? Can we change the genetic in the patient? No. Can we change and also prevent previous repeated microtraumata at enthesis? No. But what we can do, we can treat psoriasis early, especially patients with a more severe disease, especially also looking in obesity with the smoking. I know it's not so easy, but this is also a factor which is increasing the risk for the development of psoriatic arthritis. So I think it's not one factor. Today, we have signs and symptoms which are showing us that we are in a good way, that we are able to prevent psoriatic arthritis. This is the first step, and we are not at the end. And finally, if you go to the EULA, you know, it's a very nice article. It's mentioning the definition of the clinical and imaging features. So I think even the people who do not believe today on this, these people will also tell you, okay, I think this is possible. Prevention, it's possible also in a patient with psoriatic arthritis. So finally, I will say, can we prevent? Yes. And since we are in the kitchen, I'm coming from Lübeck. We have the best marzipan in the world, and it's protected geographical indication since 1996. So at the kitchen, there's something sweet as a sweet conclusion. Thank you, Neil.
Wonderful, Professor Thaçi. Thank you so much for making such a lively start to our kitchen. You can tell it's going to be super interesting. And I now hand over to my co-chair, Professor Remco van Doorn, to introduce our next speaker.
Thank you, Neil. I'm delighted to introduce Professor Luis Puig, who will present the sour part of this session. And what I would like to highlight is that Professor Puig is also a leader in the field of psoriasis research. He's director of the Department of Dermatology at the Hospital de la Santa Creu in São Paulo, and professor of dermatology at the University Autónoma de Barcelona in Barcelona in Spain, of course. His focus is clinical research on psoriasis and more specifically on psoriatic arthritis. He's been principal investigator of numerous clinical studies, and he's a member both of the Spanish Academy of Dermatology and Venereology as of the Spanish Society of Rheumatology, which makes him an ideal expert, I would say, to present on this topic. In addition, he's a member of several international societies, including the AAD, EDF, and ESDR, and he's been a board member of the EADV and president of the Psoriasis International Network. Professor Puig, if you could make your case, please, then afterwards we will be able to discuss.
Thank you very much indeed. How can I oppose my much admired friend, Professor Thaçi? Of course, in gravity intervention can contribute to prevent psoriatic arthritis. We cannot fight against the genetics, but the main topic I would like to address here is if we can prevent the transition from psoriasis to psoriatic arthritis through medical treatment, and especially with biologics. And I would like to make a comment about the effect of disease modification in psoriasis, which is not the disease which is characterized by irreversible damage. We can talk about the window of opportunity in hidradenitis suppurativa and rheumatoid arthritis. We do have a window of opportunity in psoriatic arthritis, mostly because the disease modification in psoriasis concerns especially the prevention of the development of psoriatic arthritis, even though we must remember that not all patients, as a matter of fact, most patients will not develop psoriatic arthritis. And on the other hand, we are not tackling the topic of those patients who develop psoriatic arthritis before psoriasis. I won't digress on that. What is important for us to remember is that several risk factors for development of psoriatic arthritis have been recognized. Some of them act on the long term, such as obesity, psoriasis severity, family history of psoriatic arthritis, and others on short term. And some authors have called that prodromal or subclinical psoriatic arthritis. And these are mostly arthralgia and some subclinical imaging alterations. And this is the current status of this topic. So we have some patients at high risk of psoriatic arthritis in the long term, and some patients eventually develop a high risk of psoriatic arthritis in the short term. And these are people with arthralgia and are imaging evidence of synovial or intestinal inflammation without synovitis. And clinical psoriatic arthritis, early psoriatic arthritis, has been defined as people with clinical synovitis. I would say also that clinical enthesitis would make a reasonable option for diagnosis of psoriatic arthritis. And we are trying to prevent, on one hand, the evolution of psoriasis towards psoriatic arthritis, that's disease prevention in a long-term scope. And it is more important, the disease interception, that is in the 1 to 3 years before development of psoriatic arthritis, in those patients with a high risk of transition, how can we prevent this evolution? Of course, theoretically, we all know that tissue-resident memory cells become installed in the skin. They recirculate to the skin. They recirculate through the blood vessels again to the skin, but they can also lead to joint and systemic manifestations. And it has been well recognized that in patients with psoriatic arthritis, those tissue-resident memory cells, which are CD8 positive and that come from the skin, can be found in patients with psoriatic arthritis. So perhaps if we are able to prevent the circulation of these cells, we might eventually prevent the transition to psoriatic arthritis. There's some evidence, epidemiological evidence, that we can do that. In several studies, epidemiological studies, it has been demonstrated with a similar incidence rates of 1 something per 100 patient years. In the follow-up, biologic treatment is more likely to prevent, to reduce the incidence of psoriatic arthritis than narrowband EVB, or that non-biological treatments, in this another study from Israel, or in this study from Argentina, again, there was an evidence that there was a protective effect of the biologics use as regards the development of psoriatic arthritis. We have some other studies that have shown that the survival of patients on biologics in terms of development of psoriatic arthritis is worse than that of patients who are not receiving biologics. But there's a protopathic bias in that respect, because most of these patients are those with a higher risk of developing psoriatic arthritis because of their severe psoriasis. And also some of them might have arthralgia or some prodromal signs that might be the reason to start the biologic treatment. So there is a bias. And this is a suggestion might be confirmed by the fact that those patients who do develop psoriatic arthritis do develop that early on in the course of follow-up. So there's a risk of bias in this kind of study. This is a confounding by indication. On the other hand, this study was the first to suggest that there was a difference between the different biologics that were used. And you can see here that the use of, in this case, interleukin 12-23, ustekinumab, was somehow more preventive than the use of anti-TNF-alpha agents as regards to the development of psoriatic arthritis. This might be a suggestion for a class effect. And there's a recent study in another, on the Trinex United States cohort that has shown also a difference in that interleukin 12-23 agents, and especially interleukin 23 inhibitors, might be more likely to prevent the development of psoriatic arthritis than TNF, tumor necrosis factor inhibitors. This is interesting. Recently, a Spanish study using the same database, but of the whole world, has demonstrated in a very large population of more than 1 million patients with psoriasis and 230,000 patients with psoriatic arthritis, that this interception, this decreased risk by biologics is confirmed in this global population. And even more, it has been shown that in the first line, interleukin 12-23, that is ustekinumab and guselkumab, risankizumab, decrease the risk of developing psoriatic arthritis as compared to tumor necrosis factor inhibitors. That also applies to second line, and it has been shown even that this protective effect of interleukin 23 inhibitors is even more effective than interleukin 17 inhibitors. So there might be some basis to suggest that interleukin 23 blockade, perhaps acting through tissue-resident memory cells, might be more effective in terms of prevention. There are some studies that suggest that in patients with this prodromal, with this high risk of developing psoriatic arthritis, treatment with, in this case, secukinumab has led to prevention of development of psoriatic arthritis and resolution of imaging alterations. And there's even a study with guselkumab in that patients with high risk of psoriatic arthritis development within 2 years have improved their symptoms, and none of them has developed psoriatic arthritis. So there might be a role for guselkumab as able to intercept psoriatic arthritis. Beware, because in some of these studies, for instance, with guselkumab, it has been shown that the early clinical response predicts low rates of radiographic progression in biologic-naive patients. So it seems that there's an association, but this does not mean causality. This does not mean that by using guselkumab, we will decrease as low-rate progression. So this implication is an example of the post-hoc ergo propter hoc fallacy. The same as rooster's crow before sunrise doesn't imply that roosters are those who provoke sunrise. There's another aspect that I would like to comment regarding our inability to prevent all cases of psoriatic arthritis developing psoriasis, and that's paradoxical psoriatic arthritis. It was early recognized already 7 years ago that some patients develop psoriatic arthritis even during biologic treatment, and there have been several series from the Spanish registry, and there's a very nice review that suggests that the exacerbation or appearance of psoriatic arthritis can occur in patients treated with both TNF-alpha inhibitors and ustekinumab. And it seems this is a very nice review that suggests that the incidence of psoriatic arthritis of new onset ranges from 5% to 10% of patients treated with biologics. So this is another reason to say that we cannot prevent psoriatic arthritis even in those patients who are treated with guselkumab or brodalumab and guselkumab. So it is very important for us to stratify our patients between a high risk in the short term, that's subclinical psoriatic arthritis, and the prevent development of psoriatic arthritis. And in that respect, the early identification of psoriatic arthritis with artificial intelligence or any other algorithm is very important. Also, identification which are the patients which are more likely to develop psoriatic arthritis in order to develop clinical trials that aim to prevent the appearance of this. They aim to interception. In that respect, there are several multivariable models, etc. So finally, this is the way to go. Identify those patients who should enter clinical trials. And a very good example of this kind of clinical trial, which might eventually provide proof of this ability to intercept, perhaps with IL-23 inhibitors or with some other drugs, is the PAMPA trial. But beware, my last slide is a comment. Perhaps the hazard is not proportional, and some curves might be banana, and the risk, the hazard might be not not be uniform, might change. So eventually, perhaps what we will be doing is just delaying, but not preventing the eventual appearance of psoriatic arthritis. So yes, but with some objections. Thank you very much.
Wonderful. Thank you, Professor Puig. That was really, really nice to see, and also nice to hear that viewpoint. We're also waiting for questions from the floor. I got a sense from both of your talks that when we look at population level studies, sometimes some of the granularity and differences between patients, their therapies really seem to make us think about stratification, as you both touched on, and also this question of the window of opportunity, and also maybe which therapy is used in that window of opportunity. So it looks like this is perhaps the space where, if we are moving towards the use of either electronic health records to determine which patients might be on a trajectory to develop psoriatic arthritis, or whether there may be genetic markers to help us do that. It seems like the identification of the at-risk pool for psoriatic arthritis is maybe not completely addressed. And I don't know whether you can comment on, we have the clinical markers, which we've heard from both of you, the family history, and then, I wondered whether there's any new or emerging thoughts about patterns in healthcare records, or any genetic analyses of these subsets that make us think, okay, if someone turns up a new psoriasis on this day, really, what is the best stratification we can offer? I would invite either of you to comment in terms of how you might approach this in your clinic, say, or if you look in the future.
Should I start, Neil? So
yes,
I think
please.
In my opinion, it is the holistic approach is very important. So we see that it's not sweet and sour; it's both sweet and sour. We wish that we'll have only sweet sometime or only sour, but it's not working like that. We see that until now we were always working on early detection of psoriatic arthritis, because this was the only chance for us to stop, let's say, a progression of mild psoriatic arthritis toward the very severe psoriatic arthritis. But finally, our appetite, since we are in the kitchen, is increasing. And since we are in the kitchen, we would like to eat also more, and appetite is also more of prevention. And I think in the next years, we'll probably work more on that. How can we identify these factors much earlier? If this genetic factor is, I think, very important, but also the deep, profound improvement of psoriasis in patients with a high risk, with nail psoriasis, very severe psoriasis, obese patient, all these factors should be included, because which patient will be treated with biologic? Usually the patient who have been 10 years already with a severe disease and not having any previous treatment. So it's very difficult to give an answer now if you don't have a prospective approach in the future.
I do agree. I think we really, I do agree that we need more granularity, especially in terms of phenotypic and also endotypic classification of patients. Perhaps some drugs will be effective in preventing axial disease, but not peripheral disease, or the other way around. And timing might be very important. Blocking effector cytokines might not be so relevant early on as blocking rotary cytokines. We need more knowledge about which are the drivers of the initial drivers of the inflammation in the entheses or in axial skeleton as compared to peripheral disease. So we need studies beyond clinical studies and beyond the epidemiological studies, but there's a window of opportunity, and the future looks rosy. Most interesting.
Thank you. I'll invite my co-chair to ask a question.
Thank you. It occurred to me that the discussion is mainly based on retrospective studies, the discussion that you just had. But when designing a prospective study, there are 3 parameters that need to be set. First of all, which patients would you like to include? Secondly, what's the timing? When in the disease course of the psoriasis would you start with the treatment? And then thirdly, which antibody or other treatment would you want to give? I think these complicate the possible design of such a study. Do you think it will be possible to design a study that would unequivocally provide an answer to the question that we're discussing right now? And would it also be possible to distinguish true prevention of psoriatic arthritis from delay or only suppressing the symptoms during the treatment with biologics? Maybe Professor Thaçi, if you could.
Yeah. So my personal feeling is that we can prevent, or even in some cases, we can put the psoriatic arthritis to remission. So if we cannot prevent, the other question is, once it's occurring, do we have sufficient, let's say, data that will support us that will be able to put the psoriatic arthritis in remission? Not every patient is having a severe psoriatic arthritis. This is also the disease like psoriasis coming and going. So this is a question to understand what is driving, because as Louis mentioned, there are patients who are having psoriatic arthritis without psoriasis, or at least in a mild psoriasis. So we are not really there where we would like to be. But that what is for sure, if you have an autoimmune disease, you will treat early and aggressively. You will not let somebody with an autoimmune disease 20 years untreated and then think about what kind of treatment should I do after 20 years. So early, adequate. And if I will do a trial, I will do it together with a rheumatologist, because I want to be sure that once I'm starting the trial, that the patient is not really having a hidden form of psoriatic or subclinical form of psoriatic arthritis. And I think it's difficult, but this is the only way to get the right answer. But finally, that what I think it has to be the combination of the different parameters, as I mentioned earlier, and we need a biomarker for the psoriatic arthritis in the future.
From practical and statistical purposes, I would say that we should focus our clinical trials and our studies in interception. That is, patients we have a very high risk of developing psoriatic arthritis in perhaps in 1-2 years, and perhaps this likelihood is like 80% or something like that. This is easy to develop, and these are the clinical trials that are currently undergoing. Regarding prevention, that is taking patients who might eventually be at a higher risk of developing 5 years from now psoriatic arthritis, I would say it is much more difficult to develop or to design this kind of trials, and because the numbers would have to be huge, and I really don't look forward to have the responses in that respect early on, unless we are more able to identify those patients at higher risk based on endotype, biomarkers, or whatever.
Perfect. I wanted to just ask, I guess, as we look forward, we see thresholds changing all the time. So we see increased accessibility of molecules. We see routes of delivery that are not, parenteral. We see sometimes the potential for the significant lasting economic impact and the patient impact with arthritis. And so I was curious, as in parallel with the studies that we are discussing that will help us maybe better stratify patients that might better receive these therapies in the right window, are there also moves to quantify the impact of untreated psoriatic arthritis compared to what an intervention like this might cost? That sort of cost-benefit analysis. Is that an area where we're using that to maybe change the agenda at societal and political scale? Maybe a too philosophical question, I don't know.
So I can tell you that all the payers think very short, 3 months, 6 months. And if you think in a long-term run, of course, prevention is always better than treatment. But this is a philosophical question. Would you like to give more money at the beginning, or would you like to spend it slowly until the end? So I don't know, Louis, what you think, but I think the payers in Germany are not different from the payers in Spain.
The problem is not about having a control, but about improving the standard of care for all patients. And this depends on the healthcare system. So perhaps in some patients where rheumatologists or dermatologists on the street are more reluctant to start early on really disease-modifying treatment. And in psoriatic arthritis, methotrexate might not be considered to be disease-modifying. This would change our chances to improve our patients' options or future.
Yeah.
I'd like to thank you both for your wonderful contributions. We've come up to exactly on time, so we will need to now close this session. But thank you for your talks, both very interesting and stimulating. And I also would like to thank my co-chair, Professor Van Doorn, for helping me lead this session. I would like to highlight our upcoming ESGR Kitchen on the 20th of March on non-invasive imaging in skin research by Dr. Moscarella. And that is one of the many upcoming kitchen sessions which are of the 4 flavors. All our webcasts and this webinar too are available after the show, if you like, at this link. And next slide, please. I'm really excited to invite all the members of this audience to submit abstracts to our upcoming ESDR meeting in Lisbon. Abstract submission opens on the 1st of March and closes on the 3rd of June. So please start looking at that opportunity. And finally, once again, thanks very much to our speakers, our sponsors, and have a good day. Bye for now.
Thank you.
Thank you. Bye-bye.